So Dr. Kennedy from Hospital Specialist Surgery will be our last speaker, and he's going to talk about the subject. There's no such thing as a simple ankle sprain. We all know that, but we're going to learn a lot more about it tonight. John, thank you for being with us.
Thanks very much, everybody, for having me. I just have to, okay, these are my disclosures. And so, as we said, there's no such thing as an ankle sprain. I firmly believe that. And so I have a list here of sort of the differential. If you go into Wheelbook's textbook of orthopedics, this list appears. So I think it's useful to run through these as a differential diagnosis of an ankle sprain and associated injuries. So the first thing is the ATFL. We've already heard how commonly this is injured. The lateral ligament complex is the most commonly injured complex in sporting activities. And of that, the ATFL is the most commonly injured. Now, most of these, as we've heard, will recover with triple phase rehab, but a certain percentage of them will require surgery. As we've heard earlier on from our previous speakers, that the Brostrom Gould and its modification is the most commonly performed procedure, and it does very, very well. Those patients who have high demand, such as the NFL linemen that we talked about, they will oftentimes need check rein procedures. But there are certain complications associated with both, and particularly with the Brostrom, when we get in there and these are chronic injuries and there's not much left in terms of the ATFL or indeed the CFL, then we have to think about other things. And indeed, sometimes even over-tightening that retinaculum can cause problems in the posterior facet. Again, indeed, in the anytime we use the peroneus brevis, again, we're using a dynamic stabilizer in these Jones or Jones modifications or Chrisman snooks, so we try to avoid that if possible. And again, that can certainly over-tighten the subtalar joint. So we came up with a modification, it's a hybrid, where we take actually the peroneus longus, and that's not a dynamic stabilizer, and we just take about 1/3 the diameter. We know that the diameter of the ATFL is about 6 millimeters, and we take about 1.5 centimeters of that. And then we use, just as we would it, in terms of an ACL, we use the anatomic footprint, and then we use biotine adhesive screws to hold the graft in position. And I agree with you and with Dr. Ferkel, who said that he uses the ATFL to, whatever is left of that, to plicate over this graft. And in doing so, I think we may preserve some of the proprioceptive fibers that are remnant to help with functional stability. The advantages of this we found are that it restores the normal anatomy of the ATFL. It's quite versatile. Oftentimes we won't touch the CFL as that's not commonly injured. And if so, we can plicate it and we don't have to do the traditional snook procedure. So not only do we have to look at the ATFL and lateral ligament complex, but we should also look within the joint itself. So any intra-articular pathology, again, Dr. Ferkin has shown in 2 papers that there's 90+% of these injuries will have some form of intra-articular pathology, and 50% of these will end up as some form of cartilage injury. So the dreaded green slides are out again, but this really shows us what's going on in terms of the initial insults to the joint. Normal apoptosis is reversed, and now we get a catabolic enzymatic destruction of the cartilage itself. Neutrophils being released, and it's a trophic response. It doesn't come just from the joint itself or just from the cartilage itself, but it'll also come from the synovium. So that causes a reversal of these normally glycosamine charged cells, and now we have fluid being pushed through the cartilage. It's like a fissure. Hydrostatic pressure maintains that insult until we get down to bone, and then a further catabolic response. So that's how these osteochondral lesions form. This is oftentimes what you see on MRI, and at the time of surgery, this gelatinous matrix. And so all that is very well and good, but the question is, the old question is, so what? Does that really make any difference? Should we be looking for these at the time that we do the lateral ligament reconstructions? And I think probably we should, because there's no true long-term study looking at the effect of osteochondral injuries, but there is some nice work done by Beat Hinterman in Switzerland looking at how injury to the ankle predisposes these patients to osteoarthritis. So if we are going to go after these chondral injuries, then there's 2 main types of treatment. Repair using microfracture or ACIs or various derivations of that, and then the replacement strategies such as OATS and even the newer things such as de novo. This is a case in point. There's a 22-year-old college athlete who presented several years to us, and we did the standard treatment of micropicking. 85% of orthopedic surgeons, when presented with this problem, would decide that micropicking was probably the best course of treatment. However, over the course of several years, the cartilage that this was repaired with turned or dedifferentiated back into type 1 cartilage, which as we know is inferior, and ultimately in maintaining his level of sporting activity, this degraded, and ultimately he required replacement strategies using an Oates procedure. And this talk is not long enough really to go into the complications of any of these, but it just serves to show the different type of options available. Now the extra-articular problems of ankle sprains of the peroneal tendons, the dynamic stabilizers, and again in a nice study by Di Giovanni, we've seen that over 25% of these chronic ankle instabilities will have some form of pathology to the peroneus brevis in particular. Now most of these can be treated conservatively if they're small, but if they're large, not only will we look at the ankle at the time of lateral ligament reconstruction, but we'll also look at the peroneal tendon. Now we do that with again, a similar exposure that Dr. Ferkel talked about, this oblique exposure. It allows you to look at it. But if you're worried about stenosis of the superior retinaculum, you can actually put in a small scope and you can do a tendoscopy to look at these. Indeed, in certain patients who have functional instability, and who don't have mechanical instability, have stenosis or some degree of pathology within the peroneal tendons, we will do a tendoscopy rather than an open procedure. And Marco has elucidated the 4 zones which are useful for observing the tendon in that. Zone 4 is difficult to visualize, and we truly haven't seen anything in zone 4, but zone A, B, and C rather are areas that we have looked at. So again, a case in point, this is a 28-year-old female runner who presented to us. She had chronic right lateral ankle pain, functional instability. She failed this Romberg test, but she was mechanically stable. She had good firm endpoint. She had a prominent peroneal tubercle and stenosis of the peroneal tendons themselves. And this is just what we see at tendoscopy. She'd been multiply injected in an outside facility with steroid and all this synovitis and so forth, and we're just cleaning all that up with the synovator, and we're just increasing the peroneal groove here in the fibula, and we actually remove the peroneal tubercle in this case also. Now, in a case where there's a small tear of the peroneal tendon, we'll actually just inject using sort of this Mafuli technique into the tear itself with a biological adjunct BMAC or PRP. Now this again is a patient, this is post-tendoscopy where we resected the peroneal tubercle, increased the groove, and she's back running at 10 weeks afterwards, avoiding any large incisions. Now what we call the low ankle sprain is the next thing, is the anterior process of the calcaneus. As we know, the bifurcated ligament is attached onto that. In inversion, plantar flexion type injuries, this can be torn and it can cause an avulsion of the anterior process of the calcaneus. And that shouldn't be confused with the rare but seen os calcaneus secundus, which is a small little tubercle. In any event, when this is torn off and it's large, it's greater than a centimeter, work done in the Mayo Clinic some many years ago has shown that these can be repaired or fixed. But if they're small and if they can cause problems with chronic scarring in the sinus tarsi, and again restriction of subtalar motion. And again, we typically when you do get this cicatrization within the sinus tarsi, we'll scope that and resect it. So again, a little bit divorced from the ankle itself, but nonetheless oftentimes confused, and is the fifth metatarsal or base of the fifth metatarsal, or so-called Jones fracture. For Sir Robert Jones, dancing around a maypole, injured his fifth metatarsal, and he put his name onto it. And so we know that the zone 2 and 3 are particularly poor or have a hypovascular zone, and these require fixation. Typically, again, we will fix these as a primary procedure in an athlete simply because the length of time it takes to recover from conservative treatment is far longer than in operative treatment, and the risk of refracture is higher. This is a paper that we looked at using the Charlotte screw, which I think is a very good screw. I think there's certain things that we can improve on it. But nonetheless, it allowed these patients back into sport-specific training at around 5 weeks, which was significantly less than if they had a conservative therapy. However, one of the problems we found with the screw, and indeed it's the manual on how to put it in, is that we forgot to look at, go back to the basics to look at anatomy. In fact, the original description of the high and inside incision for these screws goes right through this lateral dorsal cutaneous nerve of the sural nerve. And we did a nice little study looking at the sural nerve and where we should go and trying to avoid that. And in fact, if you just find, and we just came from there actually, the operating room earlier on today, where you find the brevis and you can just move the brevis in a plantarward position and you protect the nerve. Here's a case example, an 18-year-old who had a surgery in St. Elsewhere's. She came to us continuing with pain on the outside of her ankle joint and positive tenals. Unfortunately, the nerve was damaged and the screw head here was abutting the joint, so that was removed and replaced. Anterior impingement then, anterolateral impingement is very common. Again, it's from a hypertrophy of the synovium and the capsule, and again, typically at the time of the arthroscopy, that can be removed. Posterior impingement, we heard from Eric that, again, the transmalleolar ligament may be involved in inversion injuries, and that may tear off the posterior ligament and tear off the os trigonum or steatal lesion. And again, this is probably best addressed with arthroscopy. I think people are a little bit concerned about the arthroscopic treatment of this simply because of the juxtaposition of the neurovascular bundle. But in fact, the literature has a lower complication rate in posterior arthroscopy than it does with anterior arthroscopy. And that's just a little video of us showing removing the os trigonum. So in summary then, I think there's some questions raised here. Should we be looking at all ankle injuries in terms of pathology for cartilage? I think we certainly should be looking at perineal tendon pathology. We can't forget about the fifth metatarsal, or indeed the little bifurcate ligament. And then we have to look at the impingements, both anterior and posterior. So many thanks.
John, another great talk. I appreciate it very much. I'm going to have all the panel get together